Our next panel is going to talk about learning health and predictive analytics, and that will be moderated by our very own Marty Woodruff. Marty?
Good afternoon. Thank you all for joining. As Shelley pointed out, we're going to talk about the predictive modeling, leveraging all of the work that everybody out here does for in the analytics world. And what does it mean for us? So basically, it's taking a look at the next generation of health information exchange. It's taking those capabilities that everyone out here from all the various organizations has pushed hard and figured out how to do their calculations, their statistical analysis, and sharing it through message enrichment. First and foremost, that's the key there, message enrichment, a way to enrich the messages that are already flowing through the ecosystem. With me today, we have Dr. Akbar Waljee, who is a associate professor, internal medicine, division of gastroenterology at the University of Michigan. He is also a staff physician and research scientist, in addition to practicing medicine today. So thank you for joining us. We have Elizabeth Van Hoek. I apologize. Hoek. Thank you. I apologize. Mayan has been working with Liz and her team now for about 9 months. Yeah. Is that correct? Perfect. Piloting all of her work that she's done with Trinity Health. She leads the analytic team. She's population health program leader. Some of you may know it as CHAPI. It's the Center for Healthcare Analytics and Performance Improvements at Trinity Health. So we're excited to have her join because they've done all of that statistical analysis that needs to occur. Then we have, last and not least, Flynn. Thank you. I think most people in this room probably know you at some level. Yes. Alan is with University of Michigan Health System. He's works in various areas. He's involved with several major health IT projects. He's focused, he's working in the knowledge grid, the statewide service that's up and operational. The Learning Health Center is part of your calling. So thank you all. And I'm going to stop talking, and we're going to go to Akbar and let him start his presentation.
So again, thanks for having me here today, and thanks again for the previous panel that really highlights the importance of engaging with patients. And even though I'm a physician at the University of Michigan, it's always important to put things into context, that it's just not only about trying to cure that disease, but really incorporating the patient as a whole. I'm not only at the University of Michigan, but I also have a majority of my practice at the Ann Arbor VA, where I'm a staff physician and a research scientist. And what I'd like to talk to you today a little bit about is prediction into practice. So how can we use prediction models to help enhance the care that we provide to our patients? And the analogy that I like to use is, how we evolved in actually using maps. So I don't know if any of you have ever remember using just a latitude and a longitude to get somewhere. Well, I grew up in Kenya, and I remember when I was 11, they marked an X, and I had to trek across the Serengeti to find that spot. But man, I wish I had an iPhone. That would have been pretty amazing. And I stand up here, and you might be like, "Is he from Kenya?" Yes, I do not have that marathon physique, but I grew up in Kenya. So, we really have come a long way, right? So we come from those latitudes and longitudes to maps, to now having your iPhone giving you directions on where to go. But I feel in medicine, we really kind of have been stagnant. We haven't leveraged all that information that we have on our patients to make the right decision about when they should get the appropriate medication in a timely manner. This is what I want to talk to you a little bit about in the next few slides. So, when you have a patient that potentially can come into the ER, sometimes you have a cross-sectional view, and if they're having chest pain and you measure their labs, there might be some suggestion in that cross-sectional view whether you want to admit that patient or when you want to discharge them. But what about all that information they had in the past? In the VA, we've had the oldest electronic medical record system in the world since the 1980s with 9 million veterans. But yet, I will never use any of that additional information to potentially make a decision at that time point. And what if we could use all that information? Most of you use Amazon, right? It makes recommendations for you based on your previous buying habits, previous preferences. But what if we could use that information to help deliver care better? That can not only happen at the individual level, but you can actually have that happen at a population level. Right now, most of the people that want care are the ones that are seeking care. Right? And we talked a little bit about sort of the disparities in the social demographics that might prevent people that actually need the care in getting the care. And my hope is that predictive model can help that bridge where those who get care can actually overlap with those who need care in the slide before that. And the example that I want to use is that of hepatitis C. So most of you may be familiar that hepatitis C was a chronic disease that essentially affects an estimated prevalence between 1% to 2%, and the veteran population is about 3% to 4%. That's approximately 250,000 veterans that potentially have hepatitis C. And over time, hepatitis C goes from a normal liver to a cirrhotic liver to a cancerous liver. And we never had a good therapy for the treatment of hepatitis C. And then we got these amazing drugs. In around 2015, 2016, some amazing drugs that could cure hepatitis C at an efficacy of around, higher than 95%. Yet they came at a cost. This was a $100,000 drug. So imagine trying to cure all the veterans, 250,000 veterans, with drugs at $100,000 each. That's a lot of zeros behind that. And the VA did a phenomenal job in trying to identify patients and get them treated. But there still remain patients, the people that are not diagnosed with hepatitis C, and the people that are hard to reach people that are not seeking care in general that need to be treated. And so, the goal here was to try and use predictive modeling and look at all that longitudinal information to identify how we could best utilize these prediction models to get the right care to the right patient at the right time. And it's more than just the virus itself. I'd like to just say, hey, you have hepatitis C, I'm going to treat you. But the reality is, hepatitis C is more than just that disease, right? It's a society around them. If I treat the hepatitis C, how did they potentially get the hepatitis C in the first place? Was it heroin use? Was it opioid use? And what if we use that $100,000 to treat that patient and they get reinfected? Right? So you need to do more than just cure the patient. There's this, disparities that exist that we need to consolidate and add into our predicted model to actually identify the patients who need the right drug at the right time. We've done this in practice in a variety of different areas to optimize care and potentially to deliver high-value care. Not only have we developed models on, hepatitis C, but we've done that in colorectal cancer screening and identifying who the high-risk patients are for colorectal cancer screening. You might have heard recently that the guidelines from the American Cancer Society increased the screening for colorectal cancer to age 45. But imagine the burden that is. We obviously want to do the right thing, but how do you do it for the right patient at the right time? So this goes back to sort of our bigger picture here is that, how do we get all that data, that information? I think someone earlier today, Dr. Hyanga, essentially talked about how you can only use data if you have the data and use it wisely if you have the data. So how do we get the data available to each of us? And then how do we build these risk stratification models that help us define how we need to treat patients? And more importantly, how do we deliver the effective and efficient care? And here we talk about the importance of actually doing this and getting those models actually used into practice. So we've actually engaged with the Department of Health and Human Services, and you heard earlier from Dr. Neff, where we're trying to optimize treatment for patients who are under Medicaid to try and deliver the right drugs to the right patient at the right time. And so that's just a little short segment of what I wanted to talk about. In the future, the next panels are going to talk a little bit more in depth of how we can make this happen.
Thank you. So normally when I get up in front of folks, if I mess up how to move forward slides, no one thinks less of me. But I feel like this group, being as tech savvy as you all are, okay, good, we got it. All right, so I'm Liz. I work over at St. Joe's Health System in Ann Arbor for Trinity. And I'm going to tell you a little bit about the risk prediction that Marty keyed up that we're doing at Trinity, actually through most of our hospitals in the state. I'll use Ann Arbor as sort of an example. So I'll go into a little bit more detail in just a moment, but the risk stratification or risk score that we use is called Prism. And so the Prism story really starts with our desire to identify a small subset of patients who make up disproportionately so most of the outcomes of interest, adverse events. In this case, it'd be mortality, readmissions, length of stay, complications, and we're also seeing examples of poor HCAHPS or experience scores. So really the Pareto principle. But if we do that, can we do it in a way that all the members of the care team are using the same language, so the same risk score, and everyone can kind of coordinate around that risk score to take action? And then once we've done that, implement very specific, defined, standardized, proactive interventions to help mitigate that risk and improve the patient's experience. So kind of boiling the ocean. In fact, we started off calling this all redesigning care, which looking back, I'm a little sheepish about. We should have known better. It's not that easy. So Prism as a risk score was developed internally by the team at St. Joe's back in 2012. And what we're doing is scoring patients to identify individual patients' probability of 30-day mortality from the time of scoring. But then that's not really that's useful information, but it's not really actionable information necessarily. So then we group those predictions into 5 strata, and we call them Prism scores. So Prism 1s are our highest risk patients, and Prism 5s are our lowest risk patients. So even though the outcome of interest for Prism is 30-day mortality, you can also see on the right-hand side of the slide some of the other outcomes that we can predict with the Prism score that there's a correlation with. So it's the things you're used to seeing, things like 30-day readmissions, unplanned transfer to a higher level of care, and 180-day mortality. And then, as I mentioned, we're also seeing the relationship with poor patient experience, specifically physician communication scores and responsiveness of hospital staff. So we generate scores as patients are being admitted. So for patients coming in through the emergency department, that means that a provider in the emergency department, around the time that they've decided to admit the patient, generates the score in a web app. You can do it very quickly. We were told it had to be done in the time that an ED physician could hold their breath, and it can. And I was also very happy that particular ED physician wasn't a smoker. I was a little nervous about that. So most of the information used for scoring is pulled in electronically, and then the provider answers just a few key questions. It generates a score, and then that score is entered into the electronic medical record. For patients who are admitted for a procedure, same-day admits, we do the scoring in the, I would say, 2 to 4 days typically before the procedure. That's usually done by surgical prep center staff. So we're really good at scoring, and scoring is the stuff I like. It's the stuff I think is interesting, fun, and challenging. And for patients admitted to the Ann Arbor Hospital through the emergency department, we capture a Prism score on over 98% of them. But that's not really the important stuff. It's not the stuff that really impacts patients. So the second part of the Prism framework is the patient care framework. And so we think about a bundle, and I wish we hadn't picked the word bundle so many years ago, because that's taken on a different meaning. So care path, or a grouping of interventions or strategies or specific processes that are aligned to patient risk. And we think about that bundle of activities as being something that comes into the patient care framework right above sort of the standard care that you should get just because you have to be in the hospital. So if you're admitted to the hospital, there's just a bottom layer of the cake that should just be there. And then at the very, very tippy top of the cake, you have that sort of Dr. House, one doctor, one patient, super, super specific, that sort of high-value problem solving, and then you've got all the stuff in between. And so the Prism bundle to us goes in that in between. It's where we coordinate resources and care teams and processes and align them to individual Prism scores and strata, but not for only certain disease states or only certain types of units. So it's kind of like vanilla cake. And then you're layering on top of that maybe a sepsis bundle or maybe the specific interventions and care you get if you're in an ICU versus a general medical floor. And that framework we're finding is transferable to other settings of care, like the PCP's office, home healthcare agencies, and SNFs. We also think about the timing and that alignment. So this graph, and I know you can't see the specifics, but this is a hazard plot, starts on the left-hand side with the day of admission and goes out 180 days. The height of the line indicates the risk of mortality on that day. The red, brownish red on this slide, line that is the highest, those are our Prism 1s, our riskiest patients. And so you can see that from day one, they have the highest risk of mortality, far above the 2s and the 3s. Everyone's risk drops as they get further away from their admission. But those 1s and 2s, they still have an elevated risk over everyone else, even 180 days out. So then we think about, now that we have our patients' risk stratified, what type of risk are they experiencing at any point in time? And then what type of interventions do we want to align to mitigate that risk? So during the hospitalization, it's things like early assessment and plan of care. So in Ann Arbor, we have a standard that if a Prism 1 patient is identified in the emergency department, that they will be seen by a hospitalist with an initial plan of care and orders entered before they're taken to the floor. If they're a Prism 2, it's within 1 to 2 hours of being taken to the floor. So that's probably not something that makes sense as a general standard for all patients, but it's something that does make sense for the specific mortality risk, readmission risk, unplanned transfer risk of those Prism 1s and 2s. Now we're starting to work on things in the outpatient setting. So things like coordinating the various phone calls that a patient might get from the hospital as a post-discharge phone call, but also as a outreach phone call from their PCP's office so that patients aren't confused about how many phone calls they're getting. And we're focusing time and energy starting at the top end with 1s and 2s, our higher risk patients, and working our way down to make best use of our resources, but also to focus on where we have the most potential for changing patient outcomes and experiences. So thinking about how this kind of ties into what's been talked about today and where it's all headed, we're good at capturing scores at key points of contact. So that emergency department visit and prior to a patient being admitted after surgery. We're trying to stay very cognizant of getting the right information to the right person at the right time. And you use that same terminology several times. That's my favorite thing. So it's all about what's the right thing, the right place, the right person. So instead of just spamming everyone with this risk score all the time, who needs it when? Using Prism to stratify an entire population. So we're also working on stratifying outpatient populations for a primary care organization. But then knowing that this isn't a one-size-fits-all thing. We're never going to find one magic bullet that is the perfect risk stratification or risk score or the perfect piece of data that's going to solve everyone's problems. So can you use something like Prism to do your basic risk stratification of a whole population, and then you need to complement that with other things, and your risk score would be a great example of that. So we've implemented Prism. One last comment. We've implemented Prism at all of our Trinity sites, which are 5 hospitals in Southeast Michigan. We've implemented it now at our Grand Rapids Hospital, and then our Muskegon Hospital, the last Michigan Trinity site, is planning to go live this fall. And we're very excited about working with MyHen. Thanks.
Well, good afternoon, everyone. I'm very pleased to be here. My name is Alan Flynn from the Department of Learning Health Sciences, University of Michigan Medical School. I want to thank my panelists here for getting us off to such a great start, and our moderator as well, and thank all of you for being here for this presentation. Look forward to a discussion after I finish my brief remarks as well. My remarks are a little bit different. You've heard about 2 different initiatives to create and implement in practice predictive models. What I want to talk about as part of this panel is a statewide infrastructure and thinking forward to a world that has many, many predictive models. Today I'm referring to that as an infrastructure for calculative knowledge, things that we want to calculate and recalculate to help provide better care. And as Marty mentioned, we'll talk about a specific use that we're pursuing in conjunction with MyHIN and the team that I lead, which is the Knowledge Grid team, for enriched reporting and messaging with an HIE implementation. So 3 things I want to cover as part of these remarks. First, I'll talk and explain a little bit more what I mean about knowledge infrastructure for calculative knowledge, predictive models being the prime example in this particular panel. And then we'll talk about, in general, this health information exchange, or HIE, knowledge infrastructure story and how that enables enriched messaging and reporting. And that, of course, is statewide infrastructure, so we're very excited about the potential there to have a big impact throughout the state of Michigan. And then finally, the knowledge grid, which is technology that we've been pursuing in essentially our laboratory R&D environment in the Michigan Medical School, the Division of Learning and Knowledge Systems where I work. We now have a team of 6 or 7 individuals pursuing this technical infrastructure. So I'm trained as a pharmacist and then as an informatician. And so the talk here has a decidedly technical focus, and particularly that third part. So first up, knowledge infrastructure for calculative knowledge and predictive models. Let's talk just a little bit. Let me expand, first of all, why we think this is important, and then what I mean by calculative knowledge. So there's an argument here that we believe that more and more of this type of modeling work is going to come into our health domain in ways that are going to impact care. And as we get more and more models, we've just heard about several, but as those projects were described, actually you find out that there are multiple models that need to be thought about. So there's a Prism for a particular emergency department use in the hospital, but then there's also the potential for other models in other populations that do similar things. And so we're imagining a world with many, many of these predictive models that need to be managed. Why is that? Well, one of the things is we've all heard this buzzword of big data, so there's more and more data available in order to analyze, and it comes to us now in large registries, data networks, data lakes, a particularly Michigan word there. And of course, in the HIE context, we have lots of data flowing through the state. One example of that is ADT message sharing data, and that's part of the message enrichment story. So you're all familiar with that. Well, once we have access to lots of data, we can begin to analyze those data. This is the story of analytics. And so here, of course, we do statistical analyses, including regression analyses to build certain types of predictive models, machine learning and deep learning. All of these things that we're reading a lot about and hearing about are happening, and we have lots of this activity going on within the greater University of Michigan research community and beyond, and I'm sure you're familiar with lots of this activity as well. So what results from those analytics? Well, this is what I'm calling today calculative knowledge. And so it's knowledge about how to calculate things that we couldn't calculate before. And so calculating predictions is the main focus here, calculating estimates, calculating dosages, particularly in situations where the dosing can be complex, calculating costs. All of these things can be calculated. You know, when we were in grade school, we encountered a calculator had 4 functions. It could do arithmetic. When I was in grade school, I thought that was pretty great. And then in high school and later on in science courses in college, I encountered a scientific calculator. And it had many, many more buttons on it that I had to learn. And it could do many, many more calculations. Well, then finally now, today, I think because of this analytic story that's developing around us, all the predictive modeling work that's going on, we're essentially, conceptually, building out a new type of calculator. new buttons that we can push, new things that we can compute. And yet, we're going to have to think carefully about how to manage these new capabilities, and that's the work that I get to do every day. So when I refer to calculative knowledge, I'm referring to the knowledge that comes from doing analytics and learning how to calculate something. Well, we're anticipating more and more of this knowledge in the world in this form. And so the argument then goes that we need to think infrastructurally about how to handle calculative knowledge at scale, predictive models, again, being the prime example. And so there's this acronym you may have heard of, FAIR. And so this is what we're working toward. We're working toward making calculative knowledge fair, findable, accessible. So it's great if you can find where something is. It's even better if you can actually access it. Interoperable, we believe that's important. We have to make these things easier to deploy and use in the world technically. And so we focus a lot on the interoperability story, and I know that's been part of the discussion here this week and today as well. And in terms of fast health interoperability resources for data, we're thinking about interoperability for computable knowledge, for calculative knowledge. And then reusable. And so that's another goal that we have. How can we make it so that ultimately all the hard work that goes into creating models, we can begin to reuse those models in a variety of ways and not have to redo that work when it's not necessary in all of our organizations, but instead share some of the models that we create to calculate things. So findable and accessible, our approach to that involves having some kind of an online resource or digital library capacity so that you can do a search ultimately in some future state in your browser, find models that may be of interest, and then of course ideally have access to them. And so that's part of the story, but again, that doesn't get us to fairness. That only gets us halfway. There's more. So for any health IT system, here I'm showing a picture from the open source Vista EHR system, but this could have been any health IT system. We also need to think about interoperability and reusability. So ultimately, imagine a world where we can go to a repository, find calculators, predictive models, things like that we think are going to help us to improve care, deploy those calculators within our health IT environments, and ultimately then start driving calculations into workflows, which is precisely what was just described here. It's not enough to calculate things. You have to calculate things, and you have to figure out what the workflow will be and what the interventions are and how those calculations drive all of that. But the calculations are important in order to make that system work. And so this is what we're currently working on. And as I said, you can swap in kind of any health IT there on the right. What we're trying to do is come up with infrastructure that will support this in a general way. So next we'll talk about our health information exchange story. This is ongoing work with our group in Ann Arbor and the technical teams here also at MyHIN. And so you've probably seen diagrams like this before, where we have trusted data sharing organizations who are sharing information through the MyHIN cloud for HIE. And so we're used to seeing that once we become a trusted data sharing organization, once our organizations sign on to participate, we can start sharing information under the rules and the policies that go along with our use cases to do that. And that's the health information exchange that we're all familiar with. And so what we're working toward is being able to embed a calculative capacity, calculative knowledge, ways of calculating things directly into that HIE cloud. So adding to the network new capacity to calculate things as data are flowing through the network, and then enrich messages with the results of those calculations. So that enriched messaging and reporting is what we're ultimately wanting to deliver from the left-hand side to the right to other organizations to provide more value ultimately in the end results here. If we can do that, and do that well, I would argue that we're shining some light, we're putting knowledge into the system, ways of calculating things that are important to drive care and improve care. So as an example of this kind of enrichment, imagine what we're used to, sending ADT messages at discharge, admission into our various organizations, and now starting to enrich those messages and add on new segments that carry a variety of information that wasn't there before. So we can add things that can be calculated. Here you're seeing a couple of scores. Perhaps we want to calculate a morphine equivalent for prescription information flowing through the system. Lots of different things that we can think about to add additional information to messages that are already flowing. So this is the message enrichment story. And it's enabled by having these digital calculators available that we can deploy in a whole variety of places, including within an HIE. So then the knowledge grid infrastructure, to finish my remarks today, how are we actually doing this, what I just described? How are we doing that enrichment? Working in conjunction with the folks at MyHin. Well, we have basically 3 components that we've worked hard to create that are technical components that bring about these capabilities and move us toward this knowledge fairness. So the first thing on the left here, imagine these predictive models, these new ways of calculating things that we learned from doing analytic work, getting packaged up in an object. We call that object a knowledge object. It's a digital thing. It's a set of files that we can wrap up, and we give each one its own unique ID, and we're starting to study the life cycle of those objects so that we can manage them in the world at scale. Part of the story then is to have a digital library where we can begin collecting these. So imagine a future state in the state of Michigan. Think about, hopefully not in the near future, we'll have some sort of online repository where we can begin collecting models that can be used in a wide variety of ways to improve care in these knowledge objects. And then finally, we didn't stop there because that's findability and accessibility, but that doesn't get us to interoperability and reuse. So we went further, and we're also working on a technology that we call the Activator, which makes it easier to deploy predictive models in the world using API type of technology. So that's what the knowledge grid is. Here's a snapshot of our prototype library. So just imagine an online repository of predictive models and other calculative types of knowledge that you can ultimately go to, search, find things, and access them, and download them and begin to use them. And then the Activator, imagine a system, and we've built working prototypes of both the library and the Activator that has this capability to take the calculators out of knowledge objects that are loaded into the Activator and then compute with them. So it gives rise to an interchange, an interface. We think of that as an API, programming interface that allows other systems to send data to the Activator, get a calculation, and bring that back into our other health IT. And so that's what we're doing in the MyHin network. The folks at MyHin are sending data today to an Activator. We're running it through a couple of simple filtering mechanisms. We're doing some counting related to opioid prescribing, and then we're sending those data back out into the system. Finally, of course, at the end, none of this will help until patients and providers are receiving enriched messages that help them. And so although we're working on middleware behind the scenes, infrastructure, technology, we ultimately have to make sure that this is helpful at the end of the day, and that's why the work of implementing the prediction in practice is so critical to complement this technical work. So the Activator itself is intended to be very flexible. And so you can imagine running activators within an organization where you have an EHR and using them to begin to put calculations, where they need to be to drive care. But you can also imagine building apps that take advantage of predictive models and other calculative knowledge. And the Activator that we've created is very lightweight, and it can support that use as well. And this goes to show you how, if we think carefully about the technology that we build, we can ultimately maybe bring about an infrastructure that can be used in many different ways. The case that I just described is a case essentially of using a cloud deployment, and multiple organizations can ultimately take advantage of calculative knowledge that's implemented and deployed that way. And then finally, we don't want to leave out further research. So this same technology can be used in the laboratory to start to score data and understand even better what the next model should be. And so we want to also remind ourselves that this calculative knowledge has many uses and many users. And of course, clinical care is part of that, but it's not the only use case. Then finally, the reusability part is important as well. You're probably all familiar with data use agreements. Imagine in the not too distant future a data and knowledge use agreement where the agreement is not only to share data, but it's also to use certain types of calculative knowledge, predictive models, and other things as part of a use case. And so making sure that from a reusability perspective, we have our policy mechanisms in place which would allow us to do that in an effective way. So this is the last slide. Using these technologies, we believe, and we're progressing this story with the help of many colleagues, we believe that we can ultimately think of, in a real way, statewide sharing of certain types of calculative knowledge, not having to rebuild certain ways of calculating things that are that are useful for health, excuse me. So we've heard about today predictive hepatitis C progression models. We've heard about predicting mortality. We're also working with folks on predicting other disease risks. And then something that's come up recently that we're going to tackle this summer is to begin calculating morphine equivalents. So as our prescription information is flowing through for opioid prescriptions, this is becoming very important, these numbers, and then we want to compare to protect people. We want to understand the overall exposure that they have to narcotics. One way to do that is to begin calculating morphine equivalent scores. So today you can go out and easily find a PDF that will teach you how to do that. But having folks in practice have to manually calculate these scores is something that's taking their time away from other duties that they have. And so if we can come up with a way to build a model and share it across the state of Michigan that does these calculations, we think that could be helpful. And there are many more examples as well. So this is just the idea of infrastructure playing out at the state level. Thank you.
So thank you, all three of you, very much for your time today in the presentation. Most importantly, though, questions. Are there any questions in the audience? So while they're getting a mic over there, I have one that you all three touched on. So you all have in practice the ability to generate or score. What is the challenge? So I'll start with Trinity first. St. Joe's. How have you educated those receiving the score? How are you making them aware and what to do with it?
Yeah, so that's a good question. I think we're still in the process of figuring that out. So one of the challenges is this a score that even interests a particular group? Have they already maybe selected a different score or aren't quite interested in doing work with this type of stratification and scoring? But then, as long as we have an engaged audience, I think the trick is tying it to the outcomes and the goals that group is already after. You know, we might all like to sit around and talk about risk scoring because it's cool and fun. But if you're heading a physician's organization, what you care about is helping your organization achieve the quality and efficiency standards and goals that are going to get you the reimbursement you need and improve the lives of your patients. If risk scoring is part of that path and makes it easier, you're going to care. But if it's just us coming and telling you about this really cool thing we figured out how to do, you know, there's probably something else you'd rather spend your time on. And so we're trying to make sure we link it to the work that is important to our partners. Thank you.
Akbar, for you, same question. Your hepatitis C study at the VA.
Yeah, so I think that's a great question. I think really I've done it actually two ways. I've developed a model that I thought was important that then nobody uses, or you actually then go to the stakeholders that are actually interested in what's needed. And so if the VA is interested in a hepatitis C model, the stakeholders are engaged, and that's you're much more able to implement in those situations. So I think it's really important to identify the stakeholders involved and then actually deliver on what the interest is for not only you, but the mutually beneficial interest.
Thank you. Alan, do you have anything you want to add?
So I'll just go back to, it's a building on your question and the answers. So when we framed this particular panel, it started out with a learning health system framing. And so one of the things is, as we think about what does it mean to have a learning health system, and we imagine that we're going to do analytic work within a learning health system, we're going to generate some new models, and then we want to deploy those models in the world, And that's the work that we're talking about here, but we're not done yet, because then the next thing, of course, is we need to evaluate on a continuous basis the impact that we're actually having and study that and then feed those impacts back into the system. And so, of course, yeah, we do need to understand what's really valuable, but part of understanding what's really valuable is we have to do some learning. We won't always know until we try some things, what will be the most effective. And so our argument often about infrastructure is that we can speed up that learning process with better infrastructure.
Very good.
Hi, Tom Simmercross, and I'm going to ask the question, then I'm going to say why I'm asking it. The question is, how do you assess your predictive models in terms of incremental information that they deliver over the information that you had? And the reason that I ask that is back in the 80s when we saw Medicare's first risk adjustment sort of formula, it was able to predict 8% of the variance in terms of the cost of the members based on their risk portfolio, whereas the single question, rate your health at the time you join Medicare, good, fair, poor, was able to predict 50%. And so they've, of course, come a long way since then, some of it happy and some of it not. But as each of you were talking, I was just wondering, how do you make that assessment as to the degree to which you're adding to what was known as well? Thank you.
Yeah, that's actually a really, really great question. And just to add to your question, as, for example, a prediction model and the prevalence of the disease changes. So, 30 years ago, if there were no statins available, and now you started using statins, there's a model that was developed 30 years ago, is still effective now. And I think that's part of, the learning health cycle that we need to be more engaged in understanding, what is it that how is your disease changing? How is the population changing? Can one model in the VA necessarily work in a model that's in the Medicaid population? And I think, as we advance more into developing synthetic data sets, creating the variation, creating the medication profiles. I think the one interesting thing about the way we've done sort of modeling in the past is that we go in with a hypothesis that we think that a certain predictor is going to have a certain outcome. But I think the way sort of the commercial worlds have now been evolving is that you're looking for a pattern. A pattern exists that may actually develop a hypothesis, but a pattern that may have not necessarily engaged you as a this causes that or this is associated with that. And I think that's where we started to move sort of in the area of statistics and statistical modeling. And what we found, at least in our group, is that for the first time, the statisticians also are very engaged. Before, they were very focused on just doing chapters 1 through 5 in an exercise textbook, but now they actually have real data that they can actually evaluate and develop better models or better statistical methods.
So I think one of the really non-technical ways we found to evaluate the incremental value or information is to actually say to the teams, an example would be our nutrition team. So we would say, show me your case list, your patient list for the last couple of months. Who did you find that you think needed your services, right? And then compare that to who would have been on their list if they had built it based on the score. And so we've probably already done some of the more fancy and analytical evaluation that you're talking about, and now we're asking maybe a very particular small group of people about the value it adds in their day-to-day life. And so if you didn't have patients on your nutrition work list in the hospital who were Prism 1s, who we think would benefit from proactive nutrition counseling and healthy snacks because they are vulnerable, frail, and likely to go NPO because of tests, then there's value in you having that score. If you already found them all through other mechanisms, don't cloud your radar with it. Maybe this isn't the right piece of information to add value to you. So that's one of the ways we've tried to do it as well.
Yeah, so it's a great question. How do we know that, by putting these scores and along with the scores are not enough, and associated workflows, putting those interventions into the world, how do we evaluate them? How do we know that they're actually valuable? So, of course, I'm sure the teams here have come up with ways of measuring the impact from doing this work, and you can, I'm sure, measure it with a variety of dimensions. First and foremost being, impacts on patient care and care improvement, obviously economic measures, and a whole variety of other quality measures. So a lot of this work, I think we do this work within the context of quality improvement. And so we have measures that we are working toward improving, and if we're doing these interventions and we're seeing those improvements, then although we may not call that final proof, that's an indicator that we're getting some benefit from this information. From a purely information science perspective and thinking about prediction in particular, there are now 50 years of studies to point out to us that indeed human beings can be better informed through the use of predictive tools because it's a complement to the way experts think. So the predictive tools do calculations, they're based on statistics, they don't tell us everything we need to know, but they complement experts in the field who, from their everyday practice, gain a kind of expertise that they can then put together with these predictive tools, the scores that they get, and make better decisions. So that's been well shown in many domains, including healthcare. There are plenty of studies that kind of point us in this direction. And there are a couple of reasons why prediction is helpful. For one, it's hard for all of us to consistently analyze data. But machines can help us consistently analyze data, analyze it the same way each time. And so there's a small edge that can come from that can benefit a decision maker. And then there are some other rationale why this can be helpful in general. So as we think about infrastructure and all the good work that's being described here, there's quite a bit of scientific evidence that backs up making these moves.
Hi, Steve Golias, Blue Cross. A question really for Alan and maybe Marty, but welcome comments from the other panelists. So with respect to the notion of having models in that maybe certain entities are using and then socializing them in the HIE with a calculator framework, I guess the axiom of all models are wrong, but some models are useful sort of resonated with me. And I'm sort of wondering if you can comment on, maybe for you a model works, but maybe another entity it maybe not be as effective. Is that introducing noise in the system, and how much transparency are entities willing to share around the models that they produce so they know whether another entity is going to be comfortable with, having the same mathematics or whatever would be behind what you constructed?
Great. I'll just start. So that is an excellent question, and actually Liz's team and my team are currently having that conversation as we look at the Prism Score. And Liz, do you want to go first? Because you have great insight you were giving us great guidance,
So I think that's important, and a lot of this scoring methodology that you could purchase, it feels like a black box, right? And so it's a little bit of just blind faith. One of the reasons why we're comfortable going down this road with Prism is that it is in the public domain. So anyone, if they have the inputs, could generate Prism scores. The value really is in being able to do that in a systematic way, in a way that you can transfer it and share it, and then being a good shepherd of that and creating a book of knowledge for someone to be able to use that scoring context and make the decisions that you bring up.
Did you want to?
Yeah, so this is a really important question, and I'll kind of rephrase what I heard, and I hope I'm close. What is it that makes it so that we can transfer, our calculative knowledge from one place to another, and is it all equally transferable? And I think it's certainly the second part. I don't think it's all equally transferable. And so predictive models in particular are built using population data from particular population that describe particular populations. And so it's not appropriate to transfer those necessarily and generate a score for populations that are very different. And so that's one of the main areas where transferability comes up a lot. And you really have to think about the case that you have and the models that are available to you or the models that you might like to create and whether you can come up with a match. On the other hand, there's some calculative knowledge that's highly transferable. And so I use the example of the morphine equivalent calculator. And currently we're asking people in practice, to do these calculations. There are tables that are published. There's the math here is straightforward, but we really don't need to take the cognitive brain power of clinicians out in the field to do those types of calculations. As a pharmacist, across this country, we've been using essentially the same set of calculations to predict drug levels in patients now since those pharmacokinetic equations came out of research labs in the 1960s. And that's obviously transferable calculative knowledge. So you really have to think about context and case, and I think there's a dimension of transferability there. Some things it's quite easy probably to think about generalizing their use, other things that's not appropriate.
I had one other comment, and I think what's interesting is you were talking about calculators, and we're really talking about having done one calculation on one patient and sharing it. So I think also then the other version of transferable is if you're on the receiving end, it might not be an either or. It might not be, do I pick this one or pick that one? It might be, I have to use that score. So a patient who's discharged from St. Joe would have a Prism score to represent their readmission risk, but a patient who's discharged from the University of Michigan is not. They're going to have a LACE score, which you had up on your slide, to represent readmission risk. And the PCP in the community is going to get some of both. And so then how do we partner to say, hey, PCP, when you think about your patients who are at high risk for readmission and you want to do interventions A, B, and C, apply that to Prism 1s, 2s, and 3s, and apply that to LACE scores of greater than 19. I totally made that up because I actually forget what the cutoff was. We did a crosswalk. So I think that's the other version of it, is that you might not be using this to generate a score on a population fresh. It might be about being able to translate the information that you get that comes just with that one patient.
Thank you. Did I see another hand over here somewhere? Very good. Any other questions? Thank you very much, all three of you.